Could you give everybody just a little bit of a brief explanation about the difference between traditional hormone replacement therapy and the scale that they give you that you need to be in to be a candidate, and what that as opposed to what hormone optimization means?
Well, where do you want to start? So
I know I threw you kind of a broad topic there.
we'll start with the most obvious, and that is testosterone. And a lot of people think of testosterone as just a male hormone, but actually, testosterone is the most prevalent hormone in women until they reach the age 30. After age 30, women start to lose about half of the testosterone they're ever going to make after age 30. And the big issue with testosterone is the lack of experience of providers, because they don't know. They look at levels on paper and they treat the paper and not the patient. And for instance, the average level with any lab for a man's testosterone, total testosterone level, is 350 to 1,000. That's a huge range. But if you go into a primary care doc that's not experienced with hormone replacement and your testosterone's 355, he's going to say you're normal. And you're not normal, because the one thing that they don't look at is free testosterone level. Because about 90% of the testosterone your body is making, though it be low, about 90% of that, 90 to 99% of it's bound up by a protein. Bound testosterone does nothing to help with your symptoms. It's the unbound or the free. So I medicate patients based on their free testosterone level, not their total testosterone level. And that's where a lot of people, sometimes I'm going to say frown upon what I do, especially the doctors, because I am just a nurse practitioner. But if a patient's total testosterone level, if they have a lot of the protein that binds up their testosterone, then we're going to have to naturally get their total testosterone level higher than the usual high norm, just because it's all bound up. So guys come to me and say, I want my total testosterone at 1,000. I may need to get you to 1,500. The protein that binds up testosterone is sex hormone binding globulin, SHBG. And there's nothing that we do that makes us produce it more. It just kind of is what it is. Some guys it's higher than others. And so it binds it up. So that's in men, that's the biggest thing, is the wrong thing is treated. A lot of times the total's treated when really the free should be treated. And the norms on paper are not the norms. You have to treat the person. Most guys come to me, if your testosterone is less than 500, then your free testosterone level is probably not going to be greater than 10. I like to get your free testosterone level 20 to 30 for optimum. That's just optimum treatment. That's the best way to fine tune that hormone and optimize it the best in men. That's where they feel the best. And of course it's higher on paper, but it's the same thing with women. A woman's testosterone level on paper is not supposed to be over 50. A woman does not feel good until their testosterone levels between 200 and 300. And I use pellets in women and I use injections in men, because the pellets work better in women and the injections work better in men. And injections are not really FDA approved for women, so I don't like to use injections, because the pellets work so well. Because I'm only trying to get a woman to 200 to 300. I'm trying to get a man, 1,000 to 12 to 1,500, depending on what their SHBG level is. So it's a lot easier to achieve the goal with the women than it is the men. And you have to put a lot of testosterone in a man when you put a pellet in. So it makes pelleting a man, one, very expensive, much more expensive than women, more than twice what it costs a woman to pellet a man. And injections just work better, in my experience. I've had over my years of doing this, I've had many patients that leave me to go do pellets, because I wouldn't do pellets in men. I wasn't doing pellets at all at that time, but now I was trained by BioT, so I know how to do that, and I've learned it. But back when I wouldn't do pellets, I had guys that would leave my practice to go to pellets, and probably about 99.9% of them always came back because the pellets just don't work as well in men. And then when you look at the thyroid gland, everyone's thyroid gland can be fine-tuned and optimized to make you feel better. Okay. And just because you're on thyroid medicine doesn't necessarily mean that you're hypothyroid or you have Hashimoto's thyroiditis. It just means that the thing that everyone gauges on the planet is TSH, which is the stimulating hormone that comes from the pituitary gland that tells the thyroid hormone to make thyroid hormone. So if that number's high, that means the brain's constantly telling the thyroid gland to make thyroid hormone because it's low. So that's hypothyroidism. It's backwards because the TSH, when it's high, means that your thyroid gland is hypoproductive. And the only thing providers look at is TSH, which is that stimulating hormone coming from the pituitary gland, and free T4 or T4. There's two hormones produced by the thyroid gland, T3 and T4. T4 is inactive thyroid hormone. I compare it to total testosterone. It does nothing to do anything to help your symptoms. No one ever hardly checks T3. I check free T3. That's how much active hormone, thyroid hormone you have in your system. I want the T3 to be at the highest I can get it in the normal range. I like to get it either high 4s, low 5s, and I like your T4 to be less than 1. And if you get that, their TSH is going to be normal always, unless they just have some sort of mechanism within their pituitary that causes an overproduction of TSH, which I do have patients with that as well. And once you figure that out, I don't even look at TSH anymore. I just regulate their actual thyroid hormones. And the thyroid hormone levels are pretty precise as far as management when you look at the ranges on paper, but it's just how you do it. The medicine today looks at stimulating hormone and inactive thyroid hormone. They don't look at the active very rarely. Some docs do, but not a lot. So, and I use for treatment for thyroid replacement, I only use NP thyroid. I do not use levothyroxine or synthroids. That is number one, the most prescribed medicine on the planet is levothyroxine, and it is nothing but T4. NP thyroid or armor thyroid is T3 and T4. It's desiccated. So you're getting a little bit of both. And the way the T4 converts to T3 inside the body, because the thyroid gland itself only makes it only makes about 3 to 5% T3. All the rest of it's T4. It goes to your gut, it goes to your periphery, it goes to your heart. There's different receptor sites in your body that convert that T4 to T3. But as we age or as we have illness, it can kill off those receptor sites. So the older you are, the less you'll be able to convert T4 to T3. So you have to get some T3 artificially. So the big misnomer with that is everybody practices what Big Pharma tells them, and they just prescribe Synthroid. I have a lady that comes to my clinic, and I put her on T3. I had her thyroid gland optimized, and then she got insurance because I'm a cash clinic, and so she went to an insurance provider. I'm just going to put it that way. And the first thing he did was took her off NP thyroid. And she said, "Why are you taking me off NP thyroid?" And he said, "Because that stuff sucks and it doesn't work." And he didn't look at one number. He didn't ask her one symptom. He didn't ask her if she was feeling well, any of that. He just took her off of it, put her on Synthroid, and she was back in the same boat she was in before we started. So, it's just the way practitioners are indoctrinated these days, I guess, and taught. And I'm of the mind, if it ain't broke, don't fix it. So if somebody comes to me and says, man, I'm feeling excellent, I'm not going to touch their medicines. I'm going to leave them on what they're on. But rarely do I get that. But if I do, I just leave it alone.